Welcome, you of curious minds, to the American Academy of Optometry Foundation's clinical podcast series. In this episode, we will be discussing bacterial keratitis and how it may impact those who suffer from it. I'm Dr. Tom Quinn, and our guest expert for this episode is Dr. Suzanne Sherman. She's a former director of optometric services, assistant professor in optometric sciences at Columbia University, Irvine Medical Center in New York City, who is now transitioning to a new position, and details will be announced soon. Welcome, Dr. Sherman.
Thank you, Tom, and thank you to the Academy for having me. I'm excited to be here.
You're the perfect person for this topic. What did the authors of this paper want to explore?
I think they're really looking at the pathogenicity of the bacteria that's infecting the eye and the underlying state of the cornea, and how do we determine how severe the corneal infection is. I think they also are addressing the use and importance of culturing, and how do we predict poor outcomes in patients with corneal infection.
Okay, and what they find?
So it was pretty interesting. They found there was really no difference in entering acuity, presenting acuity between gram-negative and gram-positive cultures. And they found that they were, bacterial infections that ended up being gram-positive were more associated with the development of an AC reaction. So to me, that's something I tuck in my back pocket when I see a keratitis. They found that gram-positive bacteria represented the most common cause of bacterial keratitis. And in this case, it was a coagulase negative staph. And then for gram-negative, the most common was Pseudomonas in this cohort of patients that they were looking at. They also talked about negative outcomes, and they found that patients with diabetes, which we know are more susceptible, the larger the infiltrate size, if they have a hypopion, really poor VA, not contact lens related, which was interesting, suture related, previous ocular surgeries, previous drop use, ocular surface disease, and patients with a positive culture ended up having worse results. And if we went through each of these, they all do make a lot of sense given what we've seen clinically in the past, and also if you go through the paper a little more thoroughly, why they had negative results. Other than that, they found,
May I ask you, so they talk in the paper about gram-positive and gram-negative. We get that. They also talk about culture-positive and culture-negative. Can you just take a second and explain the differences there?
Yeah. So I'll tell you how I think about gram-positive and gram-negative, and I would be lying if I didn't tell you that I've had to relook this up a lot of times. So we learn it in maybe high school biology, and then in college, and then in optometry school, and then even throughout my time at my last practice, anytime I culture, I still had to look up the results. So I think of gram-positive versus gram-negative culture. Organisms. A gram-positive organism I think of as, the cell wall is this single layer. It's a little thicker, and it has different things that make it up, but it is a little more susceptible to antibiotics. You can be more targeted with it. Whereas gram-negative has a double layer, but it has an outer membrane, and that outer membrane is why it is less susceptible to antibiotics. So that's kind of where I group them.
Okay.
There is the difference in staining, and that also is how you can separate them. But I think most of us are not looking at that. And in terms of positive culture versus negative culture, anyone who has cultured knows that you may culture a lot, but you might not get results a lot. So there are so many factors that can make that happen. One, you can do a poor culture. If you haven't really been trained on culture techniques, often you can not be getting enough to really get a positive result. Two, often patients come in, they've already been on antibiotic drops, they've been on medications, and that also changes the result. Another example is, in this case, the gram-positive coagulase that we found is part of the normal flora, right? So we don't know 100% if that's truly if that's why it came back positive, or if that was actually the agent, the organism that we're dealing with.
Okay.
So oftentimes you will get nothing on that culture.
Gotcha. All right. Any takeaways from this paper that we could implement any changes in our care of patients based on what we found here?
So I think a couple of things. We know we have to be extremely careful in patients who have pre-existing anterior segment disease. They're more susceptible, diabetes, things like that, or patients in general who have poor ocular health. I think culturing is something that if you have the ability to use it, it can help you do a more targeted therapy for the underlying condition. And therefore, getting familiar with it and utilizing it, I think, is actually it's a tool in your pocket that can help a patient improve much faster. And we've been trained and taught to only culture the central ulcers that are large. I found in practice that even I was culturing ones that were not central and as large, and I would, when I got a positive result, it did change my treatment and management. So, if you're not successful with treating the patient without the culture, you may want to really consider it, or if you have the ability to do it from the beginning.
That's a great clinical tip. Dr. Suzanne Sherman, thank you so much for sharing your expertise with us. And thank you all for listening.
Thank you for having me.